Greetings, everyone. I'm very pleased to see you all participate in today's discussion. My name is Michelle Iandiorio, and I'm a professor of medicine and infectious diseases and work at the University of New Mexico Health Sciences Center and with the South Central HIV Education and Training Center. So very pleased to be with you all today. This session is going to talk about antiretroviral basics. I have slides prepared to go through the antiretroviral basics. However, I'm happy to stop and answer your questions throughout the session, since this session really is for you to get the questions that you have answered as much as I can do so. And I'm sure there will be others on the network today that can help with answering some of these questions as well. So just a reminder, if you're joining by this Zoom, on the bottom left-hand corner of your screen is the mute button. You can mute and unmute as you see fit. You're all muted automatically now, but if you want to say something, feel free to unmute. There's also a raise your hand feature on Zoom. If you go under the bottom row of your Zoom view and go under participants, and then you can see all of the participants join there, and they give your options right there to raise your hand or vote yes or no. So, and again, feel free to use the chat function whenever you have a question or comment. So I'm going to try to share my screen. Let's see. Hang on one second. Just takes a little while for me to get all my pieces over. Excellent. So I won't be able to see all of you, but if you'd like, when we have our discussion, feel free to show your video, or you can raise your hand. I may not be able to see you, but I'll have some colleagues who can shout out. So great. So here are our slides here. We're going to go through them. Oops. Hang on one second. Great. And let's see. Can I get somebody to let me know if it's okay? Great. Perfect. Thank you so much. And I'm going to take myself off video right now just so the audio is better. Let's see if I can do that, but I'll come back on later. So I have no conflicts of interest to disclose at this time. What we'll hope to get out of this is to identify when initiation of antiretroviral therapy is recommended in people with HIV, list their preferred antiretroviral agents for treatment-naive patients and characteristics of each, and we'll go through all of those drug classes, and explain why it's recommended to monitor for drug toxicity and check for drug-drug interactions when using antiretroviral therapy agents along with other medications. So I wanted to just review, we're talking about antiretroviral basics, but again, I sort of rewinded, and we're going to talk a little bit about HIV basic before we started in the treatment. So the natural history of HIV, and this is if we did not intervene with antiretroviral therapy, and this is in the majority of patients, although there are some exceptions. After acute infection, the circulating CD4 cells die and after infection, and then there are additional activated CD4 cells that are recruited into circulation, and so we'll see a bump up on the CD4 count, and then over about a decade or more, there's a steady decline in the CD4 count. An average 10 to 12 years after infection, someone with HIV infection will move on to stage 3 HIV, which is a CD4 count less than 200 or 14%. And at that time period, they're at higher risk for opportunistic infections. And of course, we'd love to avoid that whenever possible. So if we intervene earlier on, then with antiretroviral therapy, we stop the decline in the CD4 cell count, and so we can interrupt this decline in this CD4. So when we're talking about HIV, for that what I call the perfect first sentence, if we're describing a person with HIV, we refer to the stage and then the control of the virus. And so the stage, we use the CD4 absolute count and percentage to determine the stage, and the viral load for the circulating viral load is to determine the control or uncontrolled. So CD4, use the stage. Stage 1 is someone who is asymptomatic and their CD4 count is over 500. Stage 2 is a CD4 between 200 and 500. And stage 3 is a CD4 count less than 200 or 14%, or any CD4 count if there's an active opportunistic disease or malignancy. And so stage 3, this stage, of course, we've commonly used the term AIDS, acquired immunodeficiency syndrome, but because of the stigma associated with that and the historic meaning of that syndrome name really meant that someone was going to imminently die, and that is no longer the case. If we start someone who has stage 3 HIV on antiretroviral therapy, they can improve their CD4 and go to stage 2 and then stage 1. And so this is really much more accurate terminology to talk about the clinical assessment of a patient at this time, rather than using the term AIDS or non-AIDS. So we'd say stage 1, and then we say, is it controlled or uncontrolled? So we get plasma from someone and send it to the lab and count how many virions we see. If it's well controlled, of course, that is the goal of our antiretroviral therapy, and that goal is of undetectable viral load. If someone is suboptimally controlled or uncontrolled, right, that's when they have a significantly detectable viral load. And that's done by the HIV RNA quantitative PCR. So I can have someone with stage 1 well controlled. I can also have a stage 1 uncontrolled, let's say if they're not on their antiretroviral therapy. And in addition, I can have someone with stage 3 HIV who's well controlled. And let's say they're just starting to rebound their CD4s, or I can have someone stage 3 uncontrolled. So those two key parts in our description of HIV. So the guidelines over the years have really gotten a lot easier, so easy to remember. So it's who should we start on antiretroviral therapy? It's all people who have HIV. And this specifically is highlighted to adults because this comes from the adult guidelines, but similar for pediatric as well. If we want to reduce the morbidity and mortality in all patients with HIV, and we also want to make a public health impact by reducing infection to others, and so we start as soon as possible. And so what does as soon as possible mean? We'll talk a little bit about that, but really it's the patient needs to be ready, right? So sometimes us as clinicians are ready before the patient is, but we will, and then what are must start conditions? Let's see, and we'll talk a bit about this later on, opportunistic infections. If someone has HIV associated nephropathy, which is significant kidney disease related to HIV infection of the kidney, and then co-infection with viral hepatitis and pregnant women. We'll go more over that. I had a question about a CD4 percentage. So great, so the CD4 is the absolute CD4. So when we order a CD4 count, we're looking for the absolute CD4, and it depends on the results and how your lab runs them and gives you the results, what that exactly looks for. But look for that. Sometimes you'll also get the percentage, or they'll say CD3 to CD4, and that is the percentage. And so that's like of the lymphocytes, what percentage are CD4s, okay? So that can be more accurate to see if there's a true difference between two CD4 counts. We wanna see a significant percentage change. And in pediatrics, where their CD4 counts are different depending on how old they are, the pediatric, they monitor CD4 percentage much more than absolute counts. So just a more accurate way of checking that. So I wanted to go over, again, the antiretroviral agents, which is the point of this talk. And I think in order to understand the antiretroviral classes and their mechanisms of action, it's really helpful to review the HIV cycle. So I've split it up basically based on the mechanism of action of the drugs, and we'll go through the initial here. So if we have a free virion, and what has to happen for the HIV virus to infect an activated CD4 cell is that it needs to bind to receptors and then get in. So entry inhibitors are agents that somehow block this normal process here of the HIV binding to the CD4 receptor, and then co-receptors, either CCR5 or CXCR4, and then the membrane fusion of the HIV envelope and the CD4 membrane together in order to spill out the genetic contents and enzymes that HIV has. And so the medications that block these steps are entry inhibitors, and we're going to talk a little bit more in detail, but they include the newest FDA approved agent fostemsavir, which prevents viral entry by inhibiting the virus from attaching to the CD4. So that's that first step. Then there's a post-attachment inhibitor, and that's ibealizumab, and that blocks HIV from binding to the co-receptors. And then there's a direct co-receptor inhibitor, the CCR5 inhibitor Maraviroc, and then blocking the fusion of the two membranes is enfuvirtide. We'll talk a little bit more about that. But if we go back to the HIV life cycle, once those membranes fusion, the genetic contents and the three enzymes come out into the cytoplasm of the T cell, what our next step is the very key enzyme which needs to happen before HIV integration, and that's the reverse transcriptase inhibitor. And the reverse transcriptase enzyme is really absolutely key. We'll talk a bit more about it because it's so important in the life cycle, and also important when we're thinking about mutations that may lead to drug resistance of some of our antiretroviral therapies. But there are two different classes of medications that block the reverse transcriptase inhibitors, and those are the nucleoside reverse transcriptase inhibitors and the non-nucleoside reverse transcriptase inhibitors. And I'm going to go over those in more detail. So let's go through the entry inhibitors. And I first talked about, here's HIV on top, and the host CD4 is on the bottom, and this is an activated CD4 because HIV can only infect activated T cells. And if we look on the HIV, we have a GP41 proteins and the GP120. This GP120 will attach to the CD4 receptor, and that's really the first part that needs to happen for HIV infection of the CD4 cell. And fostemsavir, the new FDA approved medication that's has just been approved just in July, will block here this GP120 from binding to the CD4 cell. Ibealizumab, I'm so sorry, I have such trouble with that name. What that does is block, once the CD4 receptor and the GP120 bind together, the next step is for the HIV to bind to a co-receptor. And what this post-attachment inhibitor does is block this HIV from attaching to CCR5 and CXCR4 after the CD4 receptor and the HIV come together. Both of these agents are not approved for treatment-naive patients. They're both in our toolbox for patients with multi-drug resistant HIV at this time. The other entry inhibitor is the CCR5 inhibitor Maraviroc. And so that's a chemokine receptor and antagonist, and it interferes with the interaction between HIV and CCR5 specifically. It does not have activity against blocking against the CXCR4 tropic virus. And so prior to using this agent, we need to do a special test called an HIV tropism assay to determine in our patients' HIV population whether those HIV use only CCR5 or use CXCR4 or both. And so Maraviroc has activity when we use this drug only if the results say CCR5 tropic. Again, this agent is also at this time only recommended in treatment experienced patients who are drug resistant to other options. The fusion inhibitor, an older medication, really the first entry inhibitor to be on the market, is an injectable, and that was used for multi-drug resistant virus as well. and that blocks the fusion of the HIV envelope and the CD4 membrane. What about this key enzyme, the reverse transcriptase, and the two medication classes that inhibit this enzyme? There's the nucleoside reverse transcriptase inhibitor, and really what that does is it mimics the human nucleotide. So it pretends like it's one, but it doesn't have an end group where the other human nucleotides has, and so additional nucleotides cannot be added. And so it's a chain termination. So I think sort of a broken zipper. It just cannot go any further. The non-nucleoside reverse transcriptase inhibitors also interfere with this enzyme, but do it at a different binding site, and it has to do with the conformational change of that enzyme that makes it not work anymore. So these two medications, while they both have activity against the same enzyme, they can actually be used in the same patient together because they have a somewhat different mechanism of action of how they interrupt that enzyme. So let's get back to our life cycle here. And so if we go back after the receptor attachment, membrane fusion, and reverse transcriptase reverse transcription from the HIV RNA to the DNA, HIV has two other enzymes that then come into play. And the enzymes are integrase and protease. And that's our two last antiretrovirals that we're going to talk about block those enzymes. And so the integrase inhibitors inhibit the HIV genome integration into the host cell chromosome by reversibly inhibiting the HIV integrase enzyme. So it cannot have activity. If HIV were not blocked by integrase inhibitors and we're able to, once the CD4 replicates, and it replicates the HIV genome as well, part of the life cycle of HIV after it buds off of the CD4 cell and has, now you can see this enveloped virion again with this genetic material inside. Remember, the genetic material alone does not mean that that virion is infectious. And in order for that virion to become infectious to another activated CD4, it needs to be broken up into its component parts, the HIV RNA, and then the three key enzymes, reverse transcriptase, integrase, and protease. And what cuts it into those important elements is protease. And so the final medication class here in the life cycle are the protease inhibitors, which stop that important step from happening. So just to go in a little bit more detail on those last two classes, the integrase strand transfer inhibitors, and so they inhibit the HIV genome. At this point, remember, it's DNA because it's already been reverse transcribed, and it prevents it from getting in and doing what it wants to do here, which is the host DNA and then HIV DNA, but it will not allow it to do that. So that integrase strand transfer inhibitor blocks this important enzyme that's demonstrated on this photo as these protein molecules here. The protease inhibitors, they prevent that HIV maturation, and they bind to an active site of HIV protease and inhibit that enzyme. What's really interesting, I think, with all of these inhibitors, right, and the enzymes, they're the four drug classes specifically used for the treatment of HIV in most cases they're really they do activity here by binding into the site. And so an interesting thing about protease is that many of the medications can still bind in the site and have activity, even if there are multiple mutations or some, as long as they don't cause a significant conformational change that interrupt this active site. And so when we talk soon about the barrier to resistance of a medication, it often has to do with how sensitive that binding site is to any change in the conformation of the enzyme. So here's a list of all the antiretroviral agents. There are quite a few. There are many still on the market, but most of these we do not use anymore. And I've highlighted, or I'm sorry, bolded the ones that are still in either the primary recommended for treatment naive or for alternates for treatment naive. And so you can see there are many agents on this list that we no longer use regularly. And I think if you have a patient with one of these non-bolded medications, then it may be helpful to ask a colleague about switching to a more modern regimen. Many of the agents that are not bolded here, the older regimens, have more toxicity, more interactions, potentially more side effects and tolerability issues, and sometimes require more frequent dosing. And so the more modern medications are a lot easier, well tolerated. But it's really fabulous to see that we continue to have new tools in our toolbox to treat HIV. Again, just like the treatment guidelines saying who should be treated with HIV, and it's everyone basically with HIV should be on antiretroviral therapy, it's also the guidelines for initial regimen have really gotten a lot easier as well. And so the current guidelines, and these are through the IAS in addition to the HHS, both agree that a recommended treatment are 2 drugs from the NRTI class, the nucleoside reverse transcriptase inhibitor class, that's called our backbone, plus an integrase strand inhibitor. They're all alternatives that have also been shown to be effective and can be first choice in a particular patient, given other things that may be going on with that patient. And that would be those 2 NRTI backbone plus a third class, again, the INSTI, or a boosted protease inhibitor, or an NNRTI, non-nucleoside reverse transcriptase inhibitor. And there's one FDA approved regimen that is a 1 NRTI plus an integrase strand inhibitor. So you'll have these slides, and this will be helpful as opposed to trying to memorize all of this now. But if we look here, initial regimens on the left here, so all these first words are all integrase strand inhibitors or integrase inhibitors, bictegravir, dolutegravir, raltegravir, and you can see they're combined with either tenofovir emtricitabine or abacavir lamivudine. I do want to talk about a few things. Emtricitabine and lamivudine, I personally call them fraternal twins. We never use them together because they have the same activity, but they can be interchanged in the treatment. And so one could use tenofovir plus lamivudine or abacavir plus emtricitabine. Those are currently the same. And so when we look at the most commonly used agent in all of antiretroviral regimens, it would be either emtricitabine or lamivudine. So common. And then that would be combined with tenofovir and abacavir. Again, I talked about the other NRTIs that are on the market, and you don't see them in the treatment, either in treatment experience either. So it's really, we're talking about tenofovir and abacavir. If you've got a different backbone on a patient, think about switching soon. So the key things to remember here are abacavir can be associated with a hypersensitivity reaction. In those who have HLA-B5701 positive, they are more likely to have, they're at higher risk to have abacavir hypersensitivity, and so that is an absolute contraindication to using that drug. So in the United States, we do not prescribe abacavir until we have the results that return saying HLA-B5701 negative. So that's really important, and that is somewhat limiting if we're going to do rapid start. If we're going to start medications without this lab result back, that can be a barrier. And it depends on your lab, but it could take a few weeks to come back. Tenofovir, you see that name in many of these regimens, and we'll talk more about tenofovir alafenamide or diproxyl fumarate. So 2 formulations of tenofovir, and often you'll see these exchanged in the treatment guidelines here. The key with that medication, tenofovir and emtricitabine or lamivudine, they have activity against chronic hepatitis B. And so if you had a patient who was co-infected with HIV and hepatitis B, you would want to use the tenofovir emtricitabine or tenofovir lamivudine combinations for that patient. If for whatever reason in the future, someone who was on a tenofovir-based regimen were switched off for some reason, or you thought, or they developed tenofovir resistance, the HIV developed tenofovir resistance, we want to keep in mind that they would have potentially reactivation and rebound of their hepatitis B. So if we stop their hepatitis B from replicating in the liver, and all of a sudden we remove those drugs, then hepatitis B can start replicating in the liver. and cause significant hepatitis and even fulminant liver failure. And so very important to ensure that you know which patients have hepatitis B and who do not. This other one here, you'll notice there are just 2 drugs in this last row instead of 3. Our normal rules are 3 active agents, but here's an exception here, dolutegravir lamivudine, and this has been FDA approved for an initial regimen. However, there are a few cases where we would not consider this. Again, we want to avoid if the HIV viral load is quite high. So that can be most often in acute retroviral syndrome with very, very high viral loads. We'd be concerned that that 2-drug regimen would not be enough to fully suppress that virus. If the person were co-infected with hepatitis B, again, because you do not see a tenofovir component here, so that would not be recommended. And the resistance tests are not available. Again, when we talk about we want to know what someone's the HIV resistance. However, with Rapid Start, we can start antiretroviral therapy. Again, we can start one of these regimens without knowing someone's the genotype results from the resistance testing that you sent, because it's predicted that most people will be infected with a virus that is sensitive to the first-line agents. However, because I said before that lamivudine or emtricitabine is the most common medication used in HIV, it is also the most common mutation is against lamivudine or emtricitabine in people on antiretroviral therapy. And so it is possible that someone were infected with virus that does have that mutation, which would make lamivudine not work, and then it would reduce that drug to a 1-drug regimen, and that would not be advisable. And so we would want the resistance test available at that time. And usually we're thinking about this 2-drug regimen when, for whatever reason, we don't want to use tenofovir or abacavir. There are other alternative regimens, and so there are many listed here, and there are really great tables and guidelines at the website aidsinfo.nih.gov. And so I encourage you to go there and see. But we can see here is this is a boosted integrase inhibitor. These are protease inhibitors, darunavir, ritonavir, boosted with ritonavir or cobicistat, atazanavir, boosted with ritonavir or cobicistat. So these, the next 3 down, are boosted PI regimens. Doravirine and efavirenz and rilpivirine, those 3 are NNRTIs with the 2 NRTI background. And then again, at the very bottom, we have what they call nuke sparing regimens. And so you don't see tenofovir or abacavir there, right? So you see a boosted PI plus an integrase inhibitor. And here you see a boosted PI plus lamivudine. Again, those are C1. They would not be recommended as first line unless there's something particularly unique about your patient that would require you to use that particular regimen. Let's say dialysis patient or something. So what are some considerations we need to make before initiating antiretrovirals? Is the patient willing to take the medication? So that is always, of course, key. Patient autonomy. We want to reassure patients that the medications are well tolerated, that they can do it, it will be covered by insurance. And we want to also know if the childbearing potential, pregnancy tests for women who are of reproductive ability, because it may change our conversation about what medications we would want to use. I talked about why we would want to know if someone had hepatitis B, and so we check that to see if they're hepatitis B surface antigen positive or not. Many of the medications are metabolized by both the kidney and the liver, so I want to know what someone's renal function is and the likelihood that they would have renal disease. Do they have other comorbidities that may make some medications more or less attractive? So like, do they have underlying psychiatric illnesses, osteoporosis, hyperlipidemia? Maybe they have QTc prolongation already, and so I'd want to avoid an agent that can cause that, or underlying cardiac disease. What other medications are they taking, including over the counter? So I often have to ask 3 or 4 times my patient about what else they're taking over the counter, because they don't often see those as medications or drugs, and they can have some interactions with our antiretrovirals. Some antiretrovirals require food for optimal absorption of those medications, and so depending on someone's other comorbidities or their access to food, really important to know that before choosing a regimen. What is their baseline viral load in CD4? If you have this information, right? So sometimes, well, oftentimes we can start antiretroviral therapy while those labs are still cooking and we don't have the results back. But there are a few regimens where we would not use if someone had a high viral load and a low CD4 count. And so if you don't have this information, then you would not choose those regimens until you did. And then access to medications. Do they have active insurance? Are there assistance programs that you can reach out to? So there's some pros and cons here. Here are the our backbone, so the NRTI, some pros and cons. So abacavir, with some pro is you can use it in chronic kidney disease, even in dialysis. So even with a creatinine clearance less than 30, it's still okay. And there are a single tablet regimen options. The con is the hypersensitivity reaction. Please remember that if someone's HLA-B5701 is negative, that does not completely rule out that that person may get hypersensitivity reaction. So we have to be aware of that possibility when monitoring that patient. And there's some concern with abacavir, particularly starting abacavir in someone and having increased risk of cardiovascular disease events. What about tenofovir? There are two formulations of tenofovir, TDF and TAF. In patients with HIV, we have seen some reduced renal toxicity and bone toxicity in TAF as compared to the TDF. What are some pros of both of these? So there are TDF, there's a generic available, and also there are single tablet regimens that include that. The downside is the creatinine clearance needs to be 50 or higher, and there is that potential for bone and renal toxicity, including Fanconi syndrome. TAF, it's okay as long as the creatinine clearance is 30 or above. And they're also single tablet regimens, and possible weight gain as was described in the last plenary. What about the alternate agents? So we have a backbone of NRTIs, and then we use that with an integrase strand inhibitor, a boosted protease inhibitor, and an NRTI. Well, the integrase inhibitors are well tolerated. There are fewer drug interactions. They have a rapid viral load suppression. So with our PIs and NNRTIs, we often saw virologic suppression anywhere between 3 to 5 months, and actually it was considered failure if they didn't get to undetectable by 6 months. Just to give you an idea, the integrase inhibitors, we can see someone go to undetectable within 1 to 3 months, so much faster. It does have a high barrier to resistance. So what that means is that the HIV has to have multiple mutations against the integrase inhibitor in order to cause that inhibitor not to have any activity. And there are many single tablet regimens that include an integrase strand inhibitor. What are some cons? The possible weight gain. And again, we're getting more and more data that is showing weight gain. Again, we don't know what that means. Is it dangerous kind of weight or a healthy kind of weight? We need to hear more. Dolutegravir in early pregnancy. There were an absolute number of small number increase in the neural tube defects when dolutegravir was used in the first trimester. However, the overall or risk is thought to be quite minimal when we talk about how many babies actually were born with neural tube defects. And so it's not an absolute contraindication, but it is something that we have to have a conversation with our women of reproductive capacity. And then we need there are some agents in the integrase inhibitor class that can prolong QTC, so that's something we need to monitor. The boosted protease inhibitors also a very high barrier to resistance, meaning that multiple mutations in order for that class not to work, and there's good experience in pregnancy, which is really great. The cons are drug interactions. Again, they're boosted, so they interfere with the metabolism of other medications that use the same enzyme, and they have food requirements, which may or may not be a challenge for your particular patients. The non-nucleoside reverse transcriptase inhibitors are all single tablet regimens available. There are also generics available, so that's kind of a game changer there. However, they also have drug interactions. They have a lower barrier to resistance, particularly the older ones. The newer ones not as much, but still an issue. Some of the agents require a food requirement or an acidic stomach, and some of the agents are less effective with high viral loads or a lower CD4. So not really our first class to reach to, but may be acceptable in some of your patients depending on what else is going on. So antiretroviral drug interactions, a very, very key point to think about. So HIV medications are metabolized by the cytochrome P450 mechanism of the liver, and many other medications use that same enzyme. And some of the medications, let's say the inducers of that enzyme, can decrease the levels of drugs, and inhibitors can increase the level of other drugs. And so we have to check drug-drug interactions prior to starting any new medication, including non-antiretroviral agents, and if someone's having side effects, because it may be because they're not metabolizing the medications as well. And so anytime we think about antiretroviral therapy plus a new medication, or a patient who's new to you, who's coming with a list of medications, best to look at this druginteractions.org website and review and see if there are significant drug interactions that need to be addressed. The boosters specifically, so ritonavir and cobicistat, are used to boost the level of the other antiretroviral therapy, which allows the medications to be taken less frequently. So that's really convenient for patients. However, they boost that medication by reducing its metabolism. And so there may be other medications that also use that cytochrome P450 that are also boosted, and so reduce the metabolism of those other medications. And so we see that most strikingly with drug-induced Cushing's. And so if someone you would not think would have a lot of systemic absorption of an intranasal or an inhaled or intra-articular steroid injection, but because the metabolism is so slowed down and reduced that a patient can develop Cushing's or too much steroid in their system and can have complications, including weight gain, glucose intolerance, among other things. And so that's a very key issue with the boosters. Now, all of the protease inhibitors are recommended to be boosted with either ritonavir or cobicistat, and then there is an NNRTI agent, an integrase inhibitor agent, elvitegravir with cobicistat, that is also boosted. Another statins and selective serotonin reuptake inhibitors, other medications are commonly seen to interact with these boosters. What else? Some of the antiretrovirals require an acidic stomach, specifically atazanavir, which is a protease inhibitor, and rilpivirine, which is an NNRTI. So if they require an acidic stomach, then that means they should not be taken with a proton pump inhibitor. And they're also best taken with food, as the ingestion of food helps stimulate stomach acid production and helps with the absorption of those medications. The integrase inhibitors, again, a very, very common class now. There is a major drug interactions with cations. So that's really the supplements. So many of your patients will be taking a multivitamin with minerals. They may take calcium carbonate for heartburn, for like Tums. They may be taking zinc because they heard it's good for their immune system. So any of those minerals with a positive charge of cations, magnesium, zinc, calcium, iron, can interact and reduce the absorption of both of those medications. So depending on the particular drug and the cation, anywhere from 3 to 6 hours, we need to separate the integrase inhibitor from cation containing supplements. Dolutegravir does increase the dose of metformin because so many of our patients have diabetes. That is important to know about the maximum dose of metformin. If someone's on dolutegravir, an integrase inhibitor would be lower than the general population. So prevention of resistance, do we know about bictegravir increases metformin? Really great question. I have not seen that come out. And so there is not currently the recommendation to lower metformin doses in people on bictegravir. So thanks for that. And we'll stay tuned for any additional information on that. So we want our antiretrovirals to completely suppress someone's viral load. We also want to make sure that if the virus is suppressed, then there aren't new mutations that occur, and we want to prevent any development of resistance. So we need the rules are antiretroviral therapy medications from at least 2 different classes. Again, our treatment guidelines are 2 NRTIs plus an integrase inhibitor, or 2 NRTIs plus a boosted protease inhibitor or an NNRTI. We want to avoid drug interactions and again assume that there is going to be one. So prove yourself otherwise by inputting those drugs in the drug interaction website. Avoid interference with drug absorption. So again, we want to make sure someone takes it with food if that's required, make sure that they're not taking it with a mineral if that's can reduce absorption, and make sure that they have adequate stomach acid if that's an issue. And then adherence is so key to promote adherence, because medications are not like an antibiotic course where somebody has to take 10 days. This is for the rest of their life until we have that cure. And so it is not uncommon for people who are just human beings to forget, miss, maybe their life is not as structured, maybe they're just having treatment fatigue. Promoting adherence of their antiretroviral therapy is a very, very key step in ensuring that patients with HIV are as healthy as they can be. And that requires the entire healthcare team to help promote that adherence. Again, if our HIV viral load is undetectable, you're taking your medications regularly, then if they're taking their medications regularly, then there are no mutations if the virus is not replicating. And so that's really key. So one of the ways we prevent HIV resistance is to continue to have that undetectable viral load. So I really like this old image. It's a kind of older, but it works beautifully. So if we have HIV variants that are susceptible to the drug, so we say, let's say that's a wild type virus, and I take antiretroviral therapy, then that antiretroviral therapy stops that virus from replicating, and so there are not new copies made. If there is a virus that's resistant to that particular drug that the patient is on, then that resistant variant has a competitive advantage to its peers here who are susceptible. They stop replicating, but this resistant drug virus keeps replicating. And so if I check my viral load over here and I check resistance, I'm going to see this predominant population has resistance mutations, and that's when I would want to look at that test. So what are some causes of HIV resistance? So inadequate drug therapy, if people misunderstand the guidelines and we don't pick a good regimen. If there's poor adherence to medications causing subtherapeutic levels of the drug. If there's poor absorption for the reasons I mentioned previously. If there's a drug-drug interaction. If someone's infected with a resistant virus during initial infection, and that is possible, certainly less common, but it is possible, and why we get a genotype on every single patient. We don't always wait to start therapy until the resistance testing is back, but we always do check that resistance testing and change therapy if needed. And then it is possible to get super infected. If someone is well controlled on their medication and they got a new infection of HIV from someone else, and that infection is resistant to the medications the patient is on, then it will not be effective. So that is possible. So genotype testing is really a key component of choosing good antiretroviral agents. And we want to, it compares the genetic makeup of the patient's HIV versus the wild type strain, which is the strain that is basically sensitive to all our antiretroviral agents. And then it identifies known mutations that are associated with resistance to specific medications. And so that's really important for us. It can be complicated to interpret. And so there are some tools that can help you. So when do we order it? We order it prior to starting antiretroviral therapy. So if we have acute infection and entry into care, that's ideal, because at that point you can determine if someone was infected with a virus that already had a resistance mutations. If I start someone on antiretroviral therapy and they do not fully suppress after I've started medications, then I want to check. If they're on medication and they say they're very adherent, and they still have a significant viral load, then I'm concerned, and I would check it at that time as well. And what it helps me do is figure out, number one, is it true the patient's taking their medication? Because if they have a high viral load and you get a genotype and it says pan-sensitive, then that's probably an adherence or absorption issue. But it can also give you a lot of information about your best guess for the next follow-up regimen, so you can predict the regimen that would have the most activity. So we want to stop HIV from replicating, and that's really the key to antiretroviral therapy. And why do we want to do it? We want to do that because it stops the death of CD4s. And again, we talked about the stage of HIV, and we want to keep that CD4 count high, or if it's low, we want to rebound and we want to increase the CD4. But in addition to that, we've learned that it's not just about the CD4, but about just having replicating virus in our body that causes inflammation, and that inflammation increases morbidity and mortality. And that's been represented in several, multiple studies, and I've just highlighted a few here. And so we've seen this again in other viral illnesses like unsuppressed hepatitis C, right? So increased risk of morbidity and mortality, even if someone's CD4 count is quite high. If they have ongoing viral replication, they are more likely to die from cardiac events and have liver and kidney issues. One other really exciting reason why we want to start people on antiretroviral therapy is to reduce their morbidity and mortality, improve their immune system, but also from a public health standpoint, reduce the transmission to others. And we now have very good data from the HPTN 052 study, which was in serodiscordant heterosexual couples, so one with HIV uncontrolled and one without HIV. I'm sorry, one with HIV and well controlled and one without HIV, and then the partner studies, which were in MSM, men with male sex partner couples, again, one undetectable, and undetectable in these studies were a viral load less than 200. And they saw in both the HPTN 052 study and the partner 2 study that there were zero, right, none transmissions between these sexual partners when the person with HIV had an undetectable viral load. And that's where the CDC campaign, U equals U, undetectable equals untransmissible, came from. It is evidence informed and very, very important to ensure that we pass this important information on to our patients and for our colleagues, because it can really help reduce stigma, can sort of reduce the stress with their partners, and another great public health benefit. Let's see, so it says, at what time point would you expect full viral suppression, and can you please comment on viral blips? Yeah, so the viral suppression depends on the agents used. As I mentioned, the integrase strand inhibitors are more rapidly decline the viral load than the other agents, but virologic failure is considered a detectable viral load after 6 months of therapy. With the most modern regimen, really most people are undetectable by 4 months, and we can see it earlier. A blip is a small viral load, so a low-level viremia that in retrospect went away. So it's basically someone was undetectable, and then you see a viral load, and it's like, hey, it says, 150 or 200, what's that all about? And then, I repeat it in a month and it's gone back down to undetectable. And that's how you know it's called a blip, because you look backwards and you can determine it is a blip. In real time, you don't always know if it's because of virologic, if it's because of mutations or if it's because of some sort of failure in the regimen. And so you really need to follow those patients closely. We see those viral blips when there's, usually when there's some replication of the immune system, right? So we talked, it was explained in the last plenary about the reservoir, and when the CD4s are replicating, they also replicate the HIV that's integrated into that. And so sometimes if there's something that's boosting the immune system, like a vaccine, an acute illness, something super stressful, we'll see a little blip in the viral load, and then it goes away. Thanks for that question. So we talked about the goal as being on antiretroviral therapy is to be virologically suppressed, but if we look at the US population with HIV as a whole, only 51% are virologically suppressed, so we really have our work to do. 82% of people with HIV in medical care do achieve viral suppression, so if we can keep people engaged and retained in care, we have much better outcomes. And again, this takes the entire healthcare team, and so thinking about all of your colleagues who can help with this retention and care and linkage is so key. I wanted to briefly talk about rapid start, so that's becoming more recommended because of the reasons I said, because the patient with HIV has multiple benefits from starting antiretroviral therapy right away, and from a public health standpoint, there will be reduced infections to others. If every single person with HIV were on antiretroviral therapy that suppressed their virus, then there would be no new infections. And so that's really immediate, and what immediate means is somewhat controversial, but it really means as soon as possible. Starting antiretroviral therapy, we bring earlier benefits to personal health. in acute infection, maybe it may limit the viral reservoir. Again, we heard that in the last plenary. And we see that there's reduced time to linkage to care and reduced time to viral load suppression in the United States and in other resource limited areas. It's been really effective. So monitoring their response to antiretroviral therapy. So the two things I mentioned in the very beginning is I stage the HIV, and then I say if it's controlled or uncontrolled. And so that's how we're really monitoring antiretroviral therapy. We do the CD4 count at baseline about 3 months after starting antiretroviral therapy, and then anywhere from every 3 to 6 months for the next couple of years, depending on when the how high the CD4 is. Once the CD4 is in the normal range above 500, then really it's optional whether we continue to order it if the viral load continues to be suppressed. And so if there's a change in clinical status or the viral load is not suppressed, then we would run a repeat it. But at this point, we're doing it here at least annually because some of our Department of Health requirements require that particular test, but your setting might be a bit different. The viral load, we want to do it at baseline anywhere between 2 and 8 weeks after starting antiretroviral therapy. I personally usually do it every month, have them come back and check that viral load, review adherence and tolerability, and do that until they're undetectable. Once they're undetectable, about every 3 to 4 months for the first 2 years. And if nothing else is super significant in their health or there aren't any particular psychosocial challenges, then we can change that to every 6 months. So the minimum that I check people's labs are every 6 months with that viral load. And with that viral load, I also check a complete metabolic panel. So we have some time for questions or comments. I have a few cases if we have time, but that's okay if we don't. So I will feel free to unmute if you have a question, or feel free to use the chat function. Okay, I'm going to continue to do a few cases here, but I'd like to have you ask your questions. So I'll stop at any time, just ask your questions in the chat. So here I have a 32-year-old man, and he's admitted with subacute meningitis, and he's later diagnosed with cryptococcal meningitis. His HIV screen was reactive and unfortunately had never previously been tested for HIV. His current CD4 count was 98, which is 9%, with a viral load of 150,000 copies per milliliter of blood. Hepatitis B serology show he is immune to hepatitis B, and he does not have hepatitis C, and his basic metabolic panel is normal. So I'd like to hear what your thoughts are, and you can use that vote function if you'd like. Yes, no. Would you start this patient on antiretroviral therapy at this time? And feel free to use the chat function if you want to comment or unmute and share your thoughts. Great. So there are some things where we want to think through. I gave you some information, the baseline viral load and CD4, which can help us determine which medications we might want to use or not use. We know he does not have chronic hepatitis B. That's helpful. He does have an opportunistic infection. So this person would be staged. So just think about it. Stage what? And so he is stage 3 HIV because his CD4 is less than 200. And in less than 14%, and even if his CD4 were not that low, he has an active opportunistic infection, cryptococcal meningitis, and so that is stage 3 HIV. And so in one of the early slides, I said, when do we treat patients with HIV? And we treat everyone as soon as possible. And so does this person need antiretroviral therapy? Yes. Should we start it right away? Well, here's the little exception to the rule. Okay, first we learn the rules, then we learn the exception. So this person has an opportunistic infection, and it happens to be in the brain. And so what we're concerned about, what we want to happen when someone has HIV and is on antiretroviral therapy, we want that viral load to go down to undetectable, and we want immunologic rebound, right? We want that CD4 count to go from low to high. And so what could potentially happen in that case is immune reconstitution inflammatory syndrome. And so I wanted to talk a little bit about when to start antiretroviral therapy. So in people with HIV who have an active opportunistic infection, we want to start as soon as possible. So really, that was in our guideline. Active opportunistic infections, start right away. And that's the majority of cases. However, there are some possible exceptions, and it really we're continuing to build more and more data around this, and it depends on your particular patient and what else is going on and the likelihood of mortality of treating the HIV versus not. But the possible exceptions to starting right away are cryptococcal meningitis, central nervous system toxoplasmosis, and tuberculosis. And so it really has to do with that potential risk for IRIS, immune reconstitution inflammatory syndrome. So it's really a disease or pathogen-specific inflammatory response in patients with HIV that's triggered by the initiation or reinitiation of antiretroviral therapy. And in most cases, patients start with a low CD4 with high viral loads. And it's usually accompanied by a high increase in their CD4 that's pretty quick and a rapid decrease in their viral load. Usually occurs within the first 4 to 8 weeks after initiating antiretroviral therapy. And so if I go back to my cryptococcal meningitis, and I think about the brain is an enclosed space, right, in an adult where we don't have any open areas, right? So we have, if there's inflammation, so if my immune system is all of a sudden boosted and I cause swelling further, edema and swelling, then I could cause more harm than good. So you remember that cryptococcal meningitis is associated with increased intracranial pressure. If I have more inflammation in that person because now their CD4 has rebounded very quickly, then I might be concerned of even more of that problem. And so we do treat immune reconstitution inflammatory syndrome in people with cryptococcal meningitis with repeated therapeutic lumbar punctures. Sometimes we have to use a shunt. So the delay, you can see it's not like we delay it forever. So it's somewhere between 2 to 10 weeks, and there's some various trials. This is just a sample of them. So just to think, so we think we want to start antiretroviral right away. But sometimes we have to think if someone has an opportunistic infection and then if there's increased inflammation, it could cause increased mortality, then we have to pause. Again, but few exceptions to that rule. So we're just about done. I'm still looking for your questions. We'll pause here before going into the next case if there are more questions. How about a patient with stage 3 disease recently started antiretroviral therapy who then develops cryptococcal meningitis as part of IRIS? I love that question. Thank you much. So when someone has IRIS or immune reconstitution inflammatory syndrome, we do not stop their antiretroviral therapy. We continue it and then we just treat the IRIS. We try to reduce the inflammation. So again, if they had cryptococcal meningitis, that may require more addition of more therapeutic lumbar punctures. We might use corticosteroids. When people have, let's say, mild IRIS, we can sometimes use NSAIDs. So we still want them to take their antiretrovirals. If HIV nephropathy or chronic kidney disease, what regimen would you start? That's a beautiful question. And now I'm happy to say that there are multiple options of what we could use in people with kidney disease. And so it depends on what their creatinine clearance is. If it's less than 30, then we can still use abacavir as a backbone. Lamivudine is really dosed, so you would use lower doses. So basically chronic kidney disease, we don't use that fixed dose combination with the exception of dolutegravir plus rilpivirine, which that combination can be used in renal disease. Sometimes we could also use boosted darunavir with an integrase inhibitor. So again, a nuke sparing regimen. So good that we have several options at this point, which is really great. If you see thrush on clinical exam in a newly diagnosed patient, is that an indication to delay starting antiretroviral therapy? Thank you so much. Absolutely not. So the rule is start right away. And if someone has an opportunistic infection, then really start right away, right? So that's an increased likelihood that you want to start someone on therapy right away because they're having clinical disease because of immunosuppression. And so, yes, you want to start them. And if that there's no harm with IRIS and oral thrush, that doesn't happen. Okay, so really, if you think about brain infections or active tuberculosis, those are the two exceptions where you might say, I might want to wait. Otherwise, that'd be an indication to start right away. I think I have 1 minute, so we're just about finished. There's general guidelines on switching antiretroviral therapy. Yeah, so if you have to switch, we want to know, is it because of virologic failure, right? So because the virus is resistant to the drugs that you're using, is it because of toxicity, or is it because of a drug-drug interaction? And depending on that is how I would approach the switch. What we want to do, overall rules, are we do not ever want to switch from a regimen with a high barrier to resistance to a lower barrier to resistance if we can help it. And then we want to get all the prior resistance information we can before switching so that our new best guess regimen is more likely to work. So thank you so much. I appreciate your questions. Thanks for your time, and we are out of time right now. So enjoy the rest of your conference. Thank you.